This is Dr. Peter Shaughnessy from NYU Langone Orthopedics, and today we are going to discuss using the Extensor Indicis Proprius tendon to perform an opposition tendon transfer for the thumb. Our disclosures are listed here, none are relevant to this topic. Thumb opposition is an incredibly important function. It draws the thumb away from the palm to help us grasp and manipulate objects. The most important muscle for thumb opposition is the abductor pollicis brevis, which is innervated by the recurrent motor branch of the median nerve. Patients who have a high median nerve palsy, meaning their forearm median nerve innervated muscles are affected as well as their thenar musculature, have fewer tendon donor options available to restore opposition. Thumb opposition is a composite motion consisting of abduction of the thumb away from the palm, flexion in the coronal plane, and pronation to have the pad of the thumb face the pad of the middle finger, which is the definition of opposition. Restoration of this motion requires a line of pull towards the pisiform. In general, loss of thumb opposition occurs from median nerve palsy. The causes of this may vary and can occur anywhere from the brachial plexus to the carpal tunnel. Different types of nerve injuries have different severity and potential for recovery, with neuropraxic or stretch injuries having the most favorable chances. If the thenar muscles remain denervated for too long, however, atrophy will occur and reinnervation, even if successful, will not lead to restored opposition. Our patient is a 34-year-old right-hand dominant female. She suffered a right infraclavicular brachial plexopathy after a cosmetic procedure. EMG nerve conduction studies showed severe involvement of the median nerve fascicles. She had progressive atrophy of her thenar musculature over the course of the year post-injury, though she did recover some finger flexor use and sensation in the median nerve distribution. At the time of evaluation by our team, the patient had finger flexors grade 4 out of 5 force. Her abductor pollicis brevis muscle was atrophic and non-functional. She lacked thumb opposition, and this was affecting her hand function. Here we see a picture showing flattening of her thenar musculature. Notably, her passive thumb abduction is intact. This is important because tendon transfers cannot succeed without good passive motion. Here I have listed the potential treatment options for our patient. At this point, she needs a tendon transfer to restore her opposition given her thenar atrophy. Donor options are limited given her high median nerve palsy. The EIP tendon is a good option because it is innervated by the posterior interosseous nerve. The FDS for the ring finger is a classic transfer to restore opposition, but given the 4 out of 5 force of her finger flexors, it is not a great option here. The general rule is that you lose 1 grade of force when a tendon is transferred. Palmaris longus is also innervated by the median nerve and is likely weak, and this transfer really only restores thumb abduction, not true opposition. The abductor digiti minimi is typically only employed in young children. EDQ, ECU, and ECRL transfers have also been described and would be potential options for our patient. EIP opposition tendon transfer can be indicated for either high or low median nerve palsies or for combined median and ulnar nerve palsies. Contraindications to the procedure are weakened EIP muscle or radial or PIN nerve palsies. Here we see our patient's preoperative exam. You can note the thenar atrophy of her right hand. She has finger flexor function intact. Compared to the contralateral side, we can see her right thenar atrophy as well as the inability to actively abduct her thumb. Here we see that from a side view. She's unable to abduct her thumb out of her palm. Next, we test her AIN function, which is intact. And we test her EIP function by having her independently extend her index finger with her middle and ring fingers flexed. Now we are marking out our incisions, one at the dorsal aspect of the index MCP joint, one just distal to the extensor retinaculum, one over the radial aspect of the APB insertion. We are marking out the pisiform and the ECU tendon now, and then we mark out an incision just distal to that. Not shown here is a later incision we made over the forearm. Here we are dissecting down and identifying the EIP tendon on the ulnar aspect of the EDC tendon. We pull tension and ensure that our proximal incision is in the right spot. We dissect proximally and also expose the tendon. tenosynovium is removed from the tendon and is drawn into the proximal incision. We use a vessel loop around the tendon and use a non-absorbable braided suture to tag the end of the tendon. The tendon is then transected right at its insertion. The sagittal fibers are repaired to the EDC tendon using a braided non-absorbable suture. The EIP tendon is then retrieved proximally, and here we can see the muscle belly of the EIP muscle, which is typically the most distal of the extensor musculature. Here we have made our forearm incision and we're dissecting down to expose the EIP muscle belly. The EDC tendons are retracted radially, and we can see here that when we pull on the tendon distally, the muscle belly is moving. We then retrieve the tendon into the forearm incision. This is kept moist with a moist gauze. We then begin to make our subcutaneous tunnel, which goes from our dorsal forearm incision to the incision distal to the pisiform. It is very important that this tunnel is kept just over the fascia with a large amount of subcutaneous fat superficial to it, containing the dorsal cutaneous branch of the ulnar nerve. Here we've made our incision distal to the pisiform. Again, you want to be careful for palmar cutaneous branches of the ulnar nerve, and then draw the tendon through our subcutaneous tunnel using a vessel loop into the palm. We then check to see that we will have appropriate length, which we will. We make our incision over the APB insertion and expose the APB tendon. Here we can note the pale atrophic nature of the APB muscle. We then make a subcutaneous tunnel across the palm and retrieve our tendon using a vessel loop. We do not need an additional pulley because the subcutaneous border of the ulna acts as a pulley. Here we use a tendon passer to perform a pulvertaff weave. We place a single stitch prior to checking our transfer tension. Here, our thumb opposes to the PIP joint of the index finger. We would prefer it to oppose to the DIP or distal aspect of the middle finger. So we remove our stitch, pull more tension, and then place another stitch to check our tension. Here we can see the thumb opposes to the tip of the middle finger, and we're happy with that tension. We then reinforce our prior stitch and use a tendon weaver to perform a pulvertaff weave into the APB tendon once again, which we reinforce with braided non-absorbable suture. The remaining tendon is folded over itself, and the repair is once again reinforced with suture. Here we can see the thumb rest in abduction. We're happy with the tenodesis. The incisions are irrigated and are then closed. Here we're injecting local anesthetic into the incision sites to help with postoperative pain. Steri strips are placed, and then the patient is placed in a well-padded short-arm thumb spica splint. The patient was seen at 1 week for a wound check and placed back into a thumb spica splint. It is important to keep the thumb abducted to prevent first web space contracture during immobilization. At 4 weeks, the patient is able to hold her thumb in opposition. She did have a slight MCP extensor lag of the index finger. This tends to resolve over time. The patient began working with a therapist on gentle motion at this time. She was maintained in a custom-molded hand-based thumb spica splint while not working on motion. At 7-week follow-up, the patient can demonstrate excellent opposition and abduction of her thumb. She begins to wean out of her splint. She is still working with therapy on motion with no strengthening. At 3 months follow-up, the patient begins gentle strengthening exercises supervised by a therapist. In terms of expected outcomes, there are a few relatively large studies. Burkhalter, who is credited with the procedure, published his outcomes in 1973. Of the 65 patients with EIP opposition tendon transfer, 57 had excellent outcomes, 4 fair, and 4 were designated complete failures. Anderson et al. Published their outcomes on the procedure on 40 thumbs in 1991, with excellent results in 87.5% of patients, fair in 10%, and poor in 2.4%. Lemonis in 2016 published a small series of patients who underwent this procedure. They showed that average thumb abduction at 6 months was 64 degrees, which improved to 67 degrees at 12 months. They noted no donor site morbidity. Overall, this is a very reliable procedure to restore thumb opposition. Thank you for watching.